So now we have a interview lecture with Dr. Samir Bhargava. Dr. Samir Bhargava is currently a professor in ENT department at HBT Medical College and R.N. Cooper Hospital. He has been the national president of Association of Otolaryngologists of India for the year of 2020 and 2021. He is a gold medalist ranking first in both MS as well as DORL ENT. He is invited faculty at more than 70 live surgical and cadaveric workshops all over the country since 1996. He has been a course director for cadaveric FESS workshops at HBT Medical College. He is a co-author of a short textbook of ENT disease. His special interest is implementing newborn hearing screening in India and cochlear implant surgery. Along with Dr. Samir Bhargava, I'll call upon Dr. Neha Shah to interview Dr. Samir Bhargava. Dr. Neha Shah has done her MBBS from St. GS Medical College and is a private practitioner in Ghatkopar since past 3 years. She also has a degree of lactation counsel in ACLP and MIYCN from PHF1. She's helping mothers overcome breastfeeding challenges. Over to you, Dr. Neha.
Hello sir, good afternoon. So this is going to be an interview lecture where I'm going to ask Samir sir a series of questions on how we can tackle common ENT problems in family practice.
Good afternoon, everybody. At the outset, I would like to thank the GPA Association, Dr. Preeti Bhargav, Dr. Leena Bhagat, my batchmate since 1982, should I reveal the age, and Dr. Neha Shah for inviting me here. The only thing is I have been in Jamnabai school on the other side, attending parent-teacher association for my children, and this looks like an exam, and I'm on the other side. The exam period is 45 minutes. Will you give me some grace, 5 minutes?
Sure sir. Okay. So, which is the commoner in acute otitis media versus suppurative otitis media and treatment of each in brief?
So acute otitis media is an extremely common condition. In fact, if you look at literature the world over, almost 75 to 80% of children before the age of 5 would have had some episode of an acute otitis media. And so also in our practice, we find at least 2 out of every 3 children will have suffered from this. So it's a far more common condition as compared to a chronic suppurative otitis media, which, according to the last statistics when we made them guidelines, it was about 3 to 5% of the patients could be having a chronic suppurative otitis media, which also is of 2 different types. So if we talk of acute otitis media, if it's extremely mild, you can get away with just giving the patient symptomatic relief, which is in the form of anti-inflammatories. And most of these, of course, are following upper respiratory tract infections, more common in children because of the fact that their immunity is a little low, their eustachian tubes are wider, horizontal, so they'll end up with this problem. Very common in breastfed children, so we have to instruct our mothers how to feed the child. And if it doesn't get controlled or the symptoms are more, pain is more, etc., then of course antibiotics are required. And some degree of decongestants may be required if there is a significant blockage of the nose. You want me to talk in detail regarding the preferred antibiotics, etc. for this?
No sir, we want to go in brief right now. Sorry? Treatment?
Yeah.
Okay,
so,
we can have 1 or 2 examples in that
so
case.
according to the guidelines, the antibiotic in a mild case should be amoxicillin, and in divided doses for a period of 5 to 7 days. But if the patient doesn't respond, or if it's a severe infection, or if there are some red flags which means that you need to give a little higher antibiotic, then in that case, co-amoxiclav is the drug of choice, again in divided doses for a period of 5 to 7 days. And most of the children would respond to this, but if they do not, then we go on to the next line of treatment, which is cephalosporins. In fact, what is recommended is injectable ceftriaxone for a period of just 3 days, but most of the children do very well with co-amoxiclav. And if we talk about chronic otitis media, so there are basically 2 types. One is what we label as unsafe and the other is safe. So safe is where you just have a central perforation, which means that these generally will not spread intracranially or cause any kind of complications. So if the perforation is small, it may heal up on its own if the interval period between infections is fairly long. But if the perforation doesn't heal up, then in that case, we must operate these patients and close the perforation with a tympanoplasty. The results are excellent if you have taken care of predisposing factors. The other variety of otitis media chronic is the unsafe variety, which is the cholesteatoma. And this is a disease which will remain active all the time. It can spread towards intracranial. It can cause other complications inside the ear. So this, of course, needs surgery, whether it is a 2-year-old child or an 82-year-old adult.
Okay. Thank you for that, sir. There are otic drops in India with 4 combination: antifungal, antibiotic, steroid, and local anesthetic. What is your take on this, and how a patient with otitis media could get benefit out of it?
So this combination is something I will label as jugaad. Patient comes with pain, comes with fever, comes with upper respiratory infection, you give the patient an antibiotic, you give the patient a steroid, you give the patient an antibiotic. So similarly, this is a combination which is completely irrational. If the patient has a fungus in the external ear canal or going into the middle ear, and if you add a steroid ear drop, that fungus is going to flare up. This is not an invasive fungus, but it is a fungus which will flare up. Most commonly it is Candida or it's Aspergillus. So you are trying to cover all possible causes of an otitis externa or otitis media by giving an antifungal, an antibiotic, a steroid, and if the patient has a perforation, you put an antifungal and the patient will get pain, so usme local anesthetic also is added. So it's a completely irrational combination, and that is why I don't think we continue to get this, but I'm sure the government will come down on this and make a resolution and regulation that this combination should not be sold and prescribed.
Okay. How come in otomycosis, antifungal and steroids are mixed in otic in India, and what's your take on this?
So as I said, this is very irrational, and it is probably only in our country or this part of the subcontinent that this kind of a combination is available. But recently the drug controllers have passed a resolution, and this combination will no longer be available because it just doesn't make sense, because you land up with fungus actually increasing rather than that steroid helping in any kind of an anti-inflammatory property. So what should be done if the patient comes with a fungus in the ear is very gently remove whatever large mass of fungus that you can see. So what we do quite often is do a suction and remove it in the OPD, and then your antifungal drops, pure antifungal drops. You can add a little local anesthetic in that combination, because if the patient has only an external ear problem, then most of the time this antifungal drops, clotrimazole, will not cause a burning sensation. But the moment the patient tells you कि मेरे को कान में जल रहा है after putting the drops, sure enough there will be a small perforation which you have not seen while you are doing your examination. So you should actually warn your patient and you tell them that, look here, this medicine will take care of your fungus, the pain will go away within a day completely. But if you get a little burning sensation, then this may be a small perforation, because we don't want to look foolish in front of the patient when the patient comes the next time and अरे तुमको तो कान में छोटा छेद भी है. So you must kind of preempt that and tell the patient that, look here, this is possible. If it happens, do not worry. Once your infection is settled down, these tiny perforations will heal up on their own.
Okay. Since you are one of the panel members of consensus guidelines, what are the general guidelines for treating otitis media in India?
Yeah, so we did come out with the guidelines for treatment of acute otitis media, and I have already alluded to that. So it's the same thing. We look at it in a kind of a graded manner. If it's extremely mild, then you do not need to give these patients antibiotics. If it is not settling down within 24 to 48 hours, then you add amoxicillin in 35 to 40 milligrams per kg per day in divided doses. Most of the patients will respond to that, but if they do not, then you need to up it and add an amoxiclav, or rather substitute the amoxicillin with a combination of amoxiclav, again in a little higher dose, 40 to 45 milligrams per kg body weight in divided doses, and this in most of the patients works well.
Okay. So this is about something we are seeing recently, that what is the presentation and management of sudden sensory neural hearing loss?
Yeah, so this is an entity that has increased significantly in the last few years. So I remember maybe 25, 30 years back when I started my practice, I would see one odd patient in a month or 2 months coming with this sudden blockage of the ear, bilkul sunai nahi de raha hai, and you do an audiogram and this patient has a sensory neural hearing loss. So most people feel that, "Arey, kaan band ho gaya, it must be just wax, or it's just a cold." And then when you actually examine these patients, you find that there is zero response for hearing on that side. They have a complete sudden sensory neural hearing loss. And there is a very, very simple test which can be done by the patient himself or herself. The family physician can counsel them on that. So if a patient comes to you saying, "Ke, Doctor Saab, mera kaan bilkul band ho gaya hai," you peep into the ear and you do not find any obstructive pathology. You can look at the eardrum, pretty looks normal. You just ask them to do a very simple test, which is called the hum test. Hum, just hum, and you ask the patient to shut their eyes, and whether the patient is getting sound in both ears or is getting sound in the better ear. They've come with a problem in one ear. This is, I'm talking about one-sided, single-sided hearing loss. So if they tell you that ear which is blocked, I'm not hearing the hum, it's most likely 99% going to be a complete sensory neural hearing loss or sensory neural deafness. And this has to be acted upon almost with the same urgency that you would want to treat a stroke. Because if there is a window period of about 12 to 15 days, if nothing happens during this time, the patient may not recover his or her hearing. So what we actually do is give these patients a high dose of steroids. So you may start off with at least 60 to 80 milligrams of prednisolone, but if you find that the response is not there within a day or two, these are the patients who are the candidates for 1000 milligrams of solumedrol. This pulse therapy works in a fair number of patients. We also directly inject dexamethasone into the middle ear, what is known as the intratympanic injection for this sudden hearing loss. Having said that, the results will vary. We still manage, even if the patients come at the right time, you may land up only with about 30 to 40% of patients recovering some amount of serviceable hearing. That's why it should be treated as an emergency, because if you miss the bus, then you have literally missed the bus.
How does a general physician distinguish between central and peripheral causes of vertigo?
Dr. Neha, this is a topic for an entire afternoon.
You can brief us quickly.
To distinguish between central and peripheral causes, you need to delve deeply into the history. Then when the patient walks in, look at that patient carefully, do some clinical tests, and then you need some investigations. So if we talk just on the basis of history, these patients, so the peripheral causes are the ones that are related to the inner ear particularly. So whether it's the cochlea or it's the vestibular nerve, or whether it is a tumor involving the cochleovestibular nerve. And when we talk about central, we are talking about some kinds of problems that are in the brainstem or the cerebellum. So most of the time, the peripheral one both central and peripheral can come on suddenly. But the peripheral one will take a little time to settle down. So they will be giddy for quite some time. They may be severely vertiginous for quite some time. Whereas the ones that are central will quite often come with a little bit of an imbalance and not a complete rotatory vertigo. That is one. Secondly, you must ask the patient if they have any other otologic symptoms, as in, is there a tinnitus, is there a hearing loss? If that is the case, then it hints towards a more peripheral pathology. Then when you look at the patient coming in, if the patient is grossly ataxic, it is unlikely to be a peripheral cause, it would be a central cause. There are certain red flags that when you are examining the patient, which will hint towards a central pathology and not a peripheral pathology. So if the patient tells you that, oh, with the giddiness, they suddenly fell down and they have no remembrance, as in kind of a syncopal attack, then that is central. It is not going to be peripheral. If you have certain neurological symptoms coming up, if the patient has diplopia, if the patient has dysarthria, slurring, if the patient has a severely ataxic gait, if the patient has dysphagia, all these hint towards a central pathology and not a peripheral pathology. Then once you examine the patient, certain things, you have to look at the eyes, look at the nystagmus. And if you see a horizontal nystagmus, that is more likely to be a peripheral cause. And if you have a vertical or a torsional or a direction changing nystagmus, that is more likely to be a central. Then you do certain investigations, you do the hints test. So there are various ways then that we segregate into a central or a peripheral. But from the history and the basic examination, you may be able to get some idea. But sometimes it can be confusing. You need more investigations.
I think that should definitely help us a little for sure. Red flags in vertigo.
Yeah, I did mention that.
We covered that.
Yes, in fact, we label them as 4 or 5 Ds. So with the dizziness, you have dysphagia, you have dysarthria, you have dysmetria, and diplopia. So these are the 5 red flags that you need to remember whenever you're dealing with a patient with vertigo. Yeah, you need to take some time for vertigo. That's why the side change was taking a little time.
Switch. Should GP learn Epley maneuver and use it for BPPV?
Yeah, so BPPV as a diagnosis for vertigo is a fairly common diagnosis. So it's one of the most common causes for a peripheral type of a vertigo. But we have 3 semicircular canals and we have 3 on either side. Which side is causing the problem is extremely important. So before you can even think of doing an Epley's maneuver, you need to diagnose where is the pathology, which canal. So the most common canal that gets, so basically BPPV is when you have these calcium carbonate crystals which have moved out from their normal position, right? So we have this canal lith which has moved out. So we need to know which is the canal that is involved. And you need to do a Dix-Hallpike test to determine which one it is. The commonest canal that gets involved is the posterior semicircular canal. And Epley's maneuver is meant only for that canal. So if you have not diagnosed which side is the problem, which canal is the problem, then you can actually sometimes land up worsening a patient if you do a wrong maneuver.
So I think we should not.
So I would strongly suggest that we need to, in fact, it's quite difficult sometimes for the ENT or a neurologist also to be able to diagnose which exactly canal is involved and then do the Epley's correct. Because it's, BPPV has more or less become like a waste paper basket diagnosis. Earlier it used to be Meniere's. Every patient with giddiness was Meniere's disease. To tell you, only 2 or 3% of patients with vertigo peripheral will actually be having the classical Meniere's. Today, the commonest diagnosis is actually vestibular migraine or BPPV. So I think we need to diagnose the condition properly so that we do no harm. Otherwise, the patient can be quite uncomfortable for many, many days.
Okay. So we will not be touching the patient. Your favorite anti-vertigo drugs? Generic ones.
Okay. So when the patient comes with vertigo, you need to relieve that patient of their acute symptoms. So which means that if the patient is coming with fever, you're going to give a paracetamol, or you may want to give a mefenamic acid, or any of these drugs. So you need to bring down that fever. So with vertigo, my favorite drugs are prochlorperazine or dimenhydrinate. So prochlorperazine in the dose of 5 milligrams, it is available even in the mouth dissolving combination. Generally, one may not be sufficient. You can give the patient 2 at the same time, and then later on, after 6 hours, you can repeat 1. We are always very worried about the extrapyramidal side effects that can happen with these medicines. When you give them initially in these small doses, it is extremely rare for them to land up with any kind of extrapyramidal. So do not be worried about that. But this drug works the best. You also have meclizine. In fact, in US, I think none of the other drugs are available, only meclizine is available. So these are the ones that will cause a alleviation of symptoms as fast as possible. The very popular beta-histines and the cinerazines are not medicines that will give you a result immediately. And in the doses that quite often patients take, which is 8 milligrams, sometimes I feel that has more a placebo effect than anything else. Because the dose that is required, so it works on 2 principles, not only an labyrinthine sedative, but also kind of a mild vasodilator, which helps improve the circulation towards the centers controlling the balance system in the brain. So you can then put the patient on a little longer term medication. But also remember, giving any of the acute anti-vertiginous drugs for a long time is actually a disservice, because you need to give these only for 5 or 7 days. If you give it too long, then the central compensation that should take place to then take care of the giddiness gets delayed. So make sure that you always advise it only for a short period of time and not for weeks together.
Okay, sir. Any newer therapy for tinnitus?
I wish I had the answer to permanent treatment for tinnitus. I would definitely displace Bill Gates as the richest man in the world, if not Elon Musk. So tinnitus is a very distressing symptom. And a lot of these patients are so unhappy and extremely depressed. First, you need to diagnose the cause, whether it is a subjective tinnitus or is it an objective tinnitus. Objective is where people around the patient can also hear, whereas subjective is the one that only the patient can experience. So if the patients have some degree of hearing loss as well, along with the tinnitus, then if you can increase the noise awareness, which means improve the patient's hearing with whatever form, automatically if you have more sound coming in, the inner tinnitus gets suppressed. So if the patient is not been using a hearing aid, you can advise the patient, of course, provided the patient has a hearing loss. Medical treatment in some patients works, in a large number of patients does not work. So you need to then counsel your patient regarding this. Behavior therapy is what is required. So what we do nowadays is actually do something that is known as TRT, tinnitus retraining therapy, which means you map the tinnitus, you find out what frequency is that tinnitus, what is the volume of the tinnitus sound that the patient is experiencing, which can be done with an audiometry, and then give a sound which is 30 decibels or 40 decibels higher volume than that sound that the patient already has. So we've mapped the tinnitus, we increase the sound level and give this about 2 or 3 times a week for about 3 to 4 weeks. And a fair number of patients do well with this treatment. Very recently, I'm not sure whether it's already US FDA approved, we don't have it over here. It's a device called a Limire device where they stimulate by a very low electric current to the tongue and give noise therapy. So it's a new form of medication. promising results have come out. We've not yet used it over here. But yes, in years to come, as I said, people are looking for a solution. So this is what is the latest as far as tinnitus is concerned.
Okay. Is augmentin 1000 mg BD versus 625 mg TDS equivalent, and what is the correct dosage we should use?
So amoxiclav, traditionally for an adult, you are prescribing 625 milligrams twice a day. Amoxicillin is 3 times a day, but because this is a combination of amoxicillin with clavulanic acid, we use it twice a day. So we must remember why and know why clavulanic acid is added to the amoxicillin. Amoxicillin is the antibacterial. Clavulanic acid is not. It is basically tackling the beta-lactam, which is being produced by the bacteria, which is going to go and inhibit your amoxicillin. So to inhibit that, you have added clavulanic acid. Whenever there is a severe infection, you need to increase the dose of amoxicillin. We don't need a higher dose of clavulanic acid. Right? So if we want to give the patient a higher dosage in case of a severe infection, from a normal 625 into 2, which is 1250 milligrams per day, you are increasing it. So if you give the patient 625 milligrams 3 times a day, which means you are giving somewhat around 1900 milligrams, then you are giving 500 into 3, 1500 milligrams of amoxicillin. You divide that, it is in the doses. But when you are giving 1000 milligrams of amoxiclav, you are giving 875 milligrams of amoxicillin and 125 of clavulanic. So the total amount is 1500 versus 1850. So that is why you need to give co-amoxiclav 1000 milligrams BD and not 625 TDS.
Okay. Importance of, so this is something even I want to know. Importance of newborn screening for hearing defect, as we are seeing that nowadays almost all the new babies, at least in private setup, are asked to be screened. So why has it come up now?
Yeah, so this is a topic which is very close to my heart, because as national president, I had approached even the government of India to make newborn hearing screening mandatory across the country. Unfortunately, it's only in 8 states that newborn hearing screening is made mandatory. And why are we looking at making it mandatory? 1 lakh children every year are born completely deaf. Only 5,000 of these are detected and get rehabilitated. So that is the reason, and this is something where if you detect in time, you are going to be able to bring these children to mainstream school and to mainstream life. So that is why it is very important that newborn hearing screening should be made mandatory. And I'm very happy to tell you that at least Mumbai listened to us, and last year they brought out the resolution that all the public hospitals, of course private hospitals are already doing it, that public hospitals also have to do newborn hearing screening mandatory. It is still in the stage where they are trying to implement it, but yes. Now, why it is very important is because if you can detect that the child has a problem before the age of 1 month, you can diagnose where is the problem by the age of 3 months, you can start the rehabilitation by the age of 6 months. And you are in time for the child to go to normal school if it is detected well in time. That's the reason why newborn hearing screening must be made mandatory.
So I think Cooper should be the first hospital to implement in that case.
Yeah, so all the public hospitals do have the equipment, but there is some problem still regarding implementation because there are other logistics things. But yes, it is on course. It's work in progress.
So now that we spoke about newborn deafness, so nowadays we see that even in elders, sometimes the patients are not compliant with hearing aid. So in that case, what is your opinion of cochlear implants in adults? We know about cochlear implants in kids,
Yes.
but how frequently, or is it even done in adults?
Yeah, so any patient who has a significant hearing loss which cannot be treated medically or surgically is a candidate for a hearing aid. And today you have digital hearing aids, which a lot of patients are fairly comfortable with. Yes, there is a population of patients who are still not comfortable because their hearing loss may be well beyond the range of that hearing aid. So they could be having something which is not a straight graph on the audiogram, but it could be certain frequencies are still serviceable and certain which are so highly severe to profound loss that that hearing aid doesn't benefit. So then they keep saying कि हमने hearing aid तो लगाया है पर हमको सुनाई नहीं दे रहा है, हमको समझ में नहीं आ रहा है. So these are the patients, of course on a proper audiogram and other testing, are the patients who are candidates for cochlear implants. Rightly you said that we've all heard of only children being operated for a cochlear implant, children born completely deaf in both ears who are implanted. But this surgery can be done for adults with the same outcome. In fact, abroad, almost 50% of cochlear implants that are done for adults because they've already picked up their children well in advance, so they've already rehabilitated them well, and the adults. So in our country, the problem is, oh, I am already 75 years old, why should I spend on this particular thing? Quality of life is most important. If you cannot hear, you cannot communicate. If you cannot communicate, you start getting aloof, depressed. And there is enough data to now show that if the patient is not hearing well, he or she starts landing up with even memory disturbances. So that is why it's important that our senior citizens should hear well. So it is an option, yes. At least they should be aware that this is an option. Whether they exercise that option or not is completely up to them and their family.
So are we already doing cochlear implants in adults in India?
Oh yes, of course. Cochlear implants we have, yeah. So in India, 97% of cochlear implants are for pediatrics, only 3. And you can operate at 80 to 85. In India, I have done an 82-year-old. The oldest is 84-year-old patient, very fit patient, was working in a TV serial, wanted to continue to work. So why not? Internationally, 92 is the oldest.
That's great. When do we prescribe fluticasone alone versus fluticasone plus acylastine combo in allergic rhinitis?
Right, so let's dissect the two drugs. So fluticasone is an intranasal corticosteroid. Azelastine is an intranasal antihistamine. So the combination, if given, will obviously work better because you are adding two drugs which have effect on the nasal mucosa and the added combination is going to do better. But the only problem with azelastine is the bitter taste. And they have tried to mask that and it is now getting better. So the combination, if it is taken, will work better. But we always try to give minimum medication because we know that these medicines are going to be used for a very long period of time. It's a chronic disease and you need to look at some things that will give less side effects over a period of time. So what I do is start off, depending upon the severity of the allergic rhinitis, it is graded according to mild, moderate, severe, depending upon how much the patient's quality of life is affected, sleep is affected, work is affected. If it is moderate to severe, then you start off with the combination. And after a few days, once things are controlled, you can switch to plain fluticasone, which can be given for many, many weeks to many months to even many years. So that we need to remember that this drug needs to be, of course, any patient who needs any of these molecules for a very long period of time, you need to diagnose the cause. What is the cause for the allergy? Do skin testing, find out what the trigger is, and then look at something from the long-term perspective, which is even immunotherapy.
Okay. Do you advise saline nasal spray versus the famous Jalneti?
So, Jalneti patients are extremely happy, and if you tell them that Baba Ramdev ne recommend kiya, then they're even more happy. But that is on a lighter note. See, what does the nasal spray do? It is washing away any kind of allergen particles or thick mucus. It is helping your mucociliary clearance to take place. So cleansing of the nose is a very good form of treatment. You can actually treat sometimes allergic rhinitis just with nasal douches. The only thing is that a nasal spray is a low volume, low pressure drug delivery. It will work more for just moisturizing or slightly cleansing the nose. But when you need to cleanse it a little better, then you need Jal Niti. Or today you have certain devices which are shaped with a angulation to the nozzle, and you don't need to actually do all the jugglery that you try to enter from one side and only bring it out from the other side. You can just squirt these high volume, high pressure bottles, and with saline, of course, with add a little salt, and cleanse your nose, and you can do very well. And patients are happy doing this for years together. So my preference is a higher volume, higher pressure cleansing of the nose.
When do we start antibiotics in suspected case of sinusitis, and what would be the choice of drug?
So most of the time, we always feel that all sinusitis is bacterial. No, it starts off most of the time as the upper respiratory infections are viral. So in the initial stage, there is quite often no role of an antibiotic. It's only if the discharge starts becoming mucopurulent or purulent, or of course, if it is a chronic sinusitis, then in those cases, you may need to start an antibiotic. And in more acute or subacute, again, amoxiclav is the drug of choice. International enough literature showing the same. But if it is a chronic sinusitis, then we need an anti-inflammatory property also of the antibiotic. And that's where the macrolides come into play. The macrolides like clarithromycin, if given in a lower dose, not 500 milligrams BID, but 500 milligrams OD, for 3 to 6 weeks, quite often in chronic rhinosinusitis, do very well.
What is the role of oxymetazoline and xylometazoline in family practice?
So most patients who have nasal problems will report if they cannot sleep, if their nose is blocked at night. And you need to open up their nose. That's where oxymetazoline or xylometazoline does wonders. You of course need to diagnose the cause. But the caveat is, whenever you use this molecule, it should be only for 5 to 7 days and not longer. Because this medicine works very well, but it comes with its baggage of side effects. So if the nose opens up with a xylometazoline, the patient is happy doing that and will continue to buy it OTC and continue and continue. You have this entity called rhinitis medicamentosa. Rhinitis because of the medicine that you have used. So initially the effect of the drug lasts for many hours, and then gradually over a period of time it will reduce from 12 to 10 to 8 to 6, and then there is a stage where the moment you put the drops for a few minutes it's fine, and then there is something known as a rebound congestion. The turbinates, the inferior turbinates swell up, and then the patient just cannot breathe. So that is why it is very important that the family physician counsels the patients that this medicine is to be used only for 5 days and not longer. If the blockage persists, kindly diagnose the cause.
Okay. First aid of epistaxis at GP clinic.
Yeah, so sometimes epistaxis can be quite a scary picture, both for the patient as well as for the family physician. So the first thing that you need to do if the patient has just a few drops of blood, one is check the pressure of blood pressure of the patient, ask the patient to lie down with the head raised, apply the normal measures where you pinch the nose and stop the bleeding, you apply ice to stop the bleeding. But if the bleeding still persists, then you need to pack the nose. So before you can even send this patient to the specialist to see what is the cause for the epistaxis, you can use the Merocell packs that are available, very easy to use, they slip inside and then you inflate it with saline, and they will cause a circumferential pressure, and in a large number of patients, you may be able to stop the bleeding then and there. Of course, after that, the diagnosis as to why this bleeding took place is extremely important, because the epistaxis could be something as innocuous as bleeding from the little's area, naskori futi gayi, something of that sort, but it could also mean that there could be something more sinister lying behind. So for first stage, this is something that can easily be done.
Okay. This is something we all have been seeing, that there is a prolonged cough following viral URTI, and many times the cough suppressants and all are not working. So how do we tackle this prolonged cough?
Yeah, so nowadays the cough that we see post-viral is far more stubborn than it ever used to be. And I'm sure all the family physicians and all the physicians, and Dr. Tushar will bear me out on this, that most of the time we find that these patients land up with some kind of a bronchial irritation. There is some degree of bronchital element that is happening over here. So most of the time, rather than giving the patient just a cough suppressant, you need some bronchodilator, and use of the inhalers, whether you're using a combination of budesonide with formoterol or any such combination, helps these patients. You need to counsel them that, look here, you're not asthmatic, because the reluctance for taking an inhaler is always there with patients, and you counsel them and start them on the inhaler. You start them on some bronchodilator syrups. Sometimes the patients, if they just do not respond to this, it could be a post-nasal drip which is triggering the cough, or some of these patients also need to go on to an oral steroid for a short period of time.
Okay. How do we decide the use of PPIs or antacids in prolonged cough? Do we need to investigate the patient?
So chronic coughs, I would put it as 3 or 4 causes. One is a bronchitis which has got missed. A second is a gastroesophageal reflux, GRD. Third is a postnasal drip. And fourth, and very important, is drug-induced. And quite often we have patients who have been taking blood pressure medicine, or for that matter, diabetes, anti-diabetes medicines, and that could be the cause for this. So coming to your question regarding the PPIs, if you have given these patients bronchodilators, if you have stopped the antihypertensive which could have caused the problem, and it's not just the ACE inhibitors or the beta blockers that can cause a chronic cough, but less known, your telmisartans and losartans, the ARBs, the angiotensin receptor antagonists, these also can be a cause for chronic cough. And in the anti-diabetics, sitagliptin is well known to cause cough, and this is something that quite often misses our diagnosis. So if we have ruled out all that, then in that case, GRD could be a cause. So if we do a indirect laryngoscopy or a laryngoscopy for these patients, we find a typical in between the arytenoids, that is the posterior commissure area, showing some degree of inflammation, some kind of a cobblestoning happening in the posterior pharyngeal wall. And that gives us a hint that there could be a reflux, which is the cause for the cough. And you can, of course, document it by doing some manometry studies, but I think most of the time we don't land up doing that. Give the patients empirical treatment there.
Okay. So we'll be running a little fast now. So we cover all the questions. Do you think antibiotics are being overused in throat infection?
Yes, definitely. Most of the infections are viral, where you do not need antibiotics. It's only when you see frank purulent you get parenchymatous tonsillitis. That's where you may think of using antibiotics.
Which is your favorite cough suppressant?
So we've been using a lot of dextromethorphan, and the newer ones that have come up, the But my favorite continues to be codeine. But yes, it has its own side effects. So whenever nothing seems to be working, somehow I find codeine to work the best. It's available. You need a little bit of pull with your chemist.
So the standard that we see when we have a patient with sore throat, role of gargles and which gargles should be prescribed or salt water is good enough.
Yeah, so povidone iodine as a gargle is excellent because it works both as an antiseptic, antibacterial, antiviral also to some extent, and in diluted doses, of course. But yes, salt water can also be used as gargle. It has an antiseptic property, and you can use that. We've used this with ginger, with honey, and so many things. And I'm sure these also work well. But yeah, I continue to use more of povidone iodine, betadine gargles.
In acute hoarseness of voice, can GP give any trial therapy before referring?
Yeah, so if I enumerate, acute hoarseness can be due to viral infection or bacterial infection, could be due to overuse, you've shouted, screamed, or it could be neurological. So if it's the first two, if you give some medication, a lot of time these patients will recover, at least they will be better by day 3 or day 4 or day 5. But if there is no improvement, there is breathiness in the voice, then you can be dealing with a acute vocal cord palsy. And that's why the patient needs to be seen by the otolaryngologist to diagnose the condition.
Preferred line of management for tonsillitis and indications of tonsillectomy in brief.
So if it is a bacterial infection, when you look at the throat, you realize that, then you start the patient on antibiotics and antiseptic gargles and anti-inflammatories, etc. And if we find that this kind of a picture keeps happening many times in a year, so in my book, I would say more than 4 episodes of acute tonsillitis in a calendar year or more than 5 in 2 years would be a reason enough for the tonsils to be addressed for a permanent solution. But having said that, we are doing lesser and lesser tonsillectomies today. Adenoids is a bigger problem that we face nowadays.
Last question of the session. In OSA, that is obstructive sleep apnea, should we refer to ENT for any surgical management?
Yeah, I think we've kept this question last because in 45 minutes I was observing if anybody is snoring. Any candidates for surgical treatment for OSA? So OSA is something that, of course, the ENT surgeon should be treating because it's a problem in the upper airway. It is due to narrowing in your breathing passage, a bottleneck which causes a traffic jam. So you need to diagnose where is the problem. You need to know how much is the problem. So you do a sleep study, find out what the AHI is, and then do a endoscopy to find out where the problem is. It could be as simple as nasal polyps, deviated nasal septum, adenoids, a long uvula. It could be a very prominent base tongue. So depending upon the cause, you can address these patients. But having said that, every patient with sleep apnea is not a surgical candidate. If the BMI is high, first go and reduce weight. But there are some patients who, in spite of doing all that, cannot sleep well. We know the medical problems that OSA can cause, and get it evaluated properly so as to, we need the right patient and the right surgery. Then only the patient will be benefited by it.
Okay, sir. Thank you for your quick inputs for our family practice.
Thank you very much.
May I call upon Dr. Preeti Bhargava to felicitate Dr. Samir Bhargava?